call to order the June 24 meeting of the Special Committee on Academic Health of the University of Minnesota Board of Regents. Good morning to everybody here. Thank you for joining us in this West Committee room. Today's meeting is not being live streamed, but recording is being placed, and that will be uploaded on the board's YouTube channel after today's meeting. Quick reminder that the West Committee room has room-wide microphones, so make sure you are projecting when you speak, and I'll ask the audience members to limit side conversations. And before we move to our first agenda item, I want to invite Interim President Edinger to provide a few remarks. Yeah.
Well, thank you so much, Chair Wheeler and the rest of the committee. This committee was initiated at the July board retreat last year, the same board retreat. It was my first board meeting and the time when the board gave me my priority list for the year. And indeed, this whole area of academic health has been one of those priorities, and I've certainly been involved in that. We had an old joke in the meat industry that a chicken is involved in producing an egg, but when it comes to the bacon, the hog is totally committed. So I've been involved in this process, but I just want to take this opportunity to point out that Dr. Tolar is totally committed. Dr. Tolar works on a regular basis with the deans you're going to hear about today. He works on a regular basis running our fantastic medical school. He has his own medical practice. He's expanded our medical practice through the great partnership with Centric Care. And in addition to all of those things, this past year has seen the task force that you and Dean Tolar and Dean Delaney served on that was named by the governor, and then extensive involvement with the future of our medical system with the Fairview Partnership and many other things. And I just want to take this opportunity to express my appreciation for the partnership and the hard work that Dr. Tolar puts in every day. Thank you for this opportunity.
That's great. Thank you for that recognition, Interim President Edinger, and deserved, Dean Tolar. So now we'll move into the first agenda item, which is again an update on the health sciences strategic planning. So I will invite the presenters up, Dean Delaney from School of Nursing, Dean Mays from School of Dentistry, Dean Mulgard from College of Veterinary Medicine, Dean Pettigrew from Public Health, Dean Wellage from the College of Pharmacy, and of course Dean Tolar from Medical School and as the Vice President of Medical Affairs. So I will turn it to you.
Thank you, Chair Wheeler, Vice Chair Johnson, President Edinger, and committee members. I cannot resist, but thank you. I'm humbled and honored by your comments, President Edinger, and it brings to mind one of my heroes wrote, I cannot compare myself to a hog, but at least not favorably, I'm not that useful, but what stuck with me, he said, it's better to be Socrates unhappy than a pig happy. So we are here today in front of you for the second time, my fellow deans, and we are here to seek advice from this committee and from this room on how we go forward in the direction that the task force of the governor has given to us. And I am honored to be able to serve, as one of the 6 deans, and stress first and always that together we can amplify the goodness in each individual school. So as you, Chair Wheeler, have pointed out a couple times in the past, it is really not for each of the schools to somehow externalize their achievement. It's really the interface where we combine. And as you have heard several times from me and others, we are one of the 4 universities in the United States that has the extreme benefit and extreme fortune to have all the 6 health science schools on the same campus. Now, together, we, I think, sit in front of you, to be the evidence and example of the fact that academic health matters to the state of Minnesota. This is where things happen in the workforce, in the whole person health, and in the intersection of the other parts of the university. Now, we will today present to you progress on our planning, and we will seek your feedback on the ideas and your support. With that, I'd like to ask Dean Wellage to take over.
Sign.
We're working on the slides.
Okay, you're on the slides. I'll wait for the slides.
Okay. Here, plugged in. I'm sorry, this one too, all right. Which goes on the other side. Sorry, you don't have the most competent tech support in me.
This is going well.
Let's go for it.
It's extending our display. Oh, extending, sorry. So sorry. Which one, the HDMI? Start from beginning right up here, hopefully. Okay. I'm not sure what's happening. I don't know that it's the computer's problem. It's the display. It's gonna, I don't know. Problem is that it thinks there's. It's, yeah. There you go. Show off. Yeah, let's maybe try the screen. The screen should be fine. Yeah.
I think I can do it from here.
Okay, I might need to.
Yay.
He's got it.
Okay.
You've been sitting on that this whole time?
Thank you.
Just let me know when you need to.
All right.
Yeah, thank you.
And I will say you can advance
Okay.
the slides. And I just wanted to echo some of the comments that Dr. Toller mentioned in that we collectively, the health science teams, have been working hard, collaboratively on the strategic plan. And it's our honor, with excitement and enthusiasm, we share the preliminary. And so I want to stress that's preliminary because we want input and we want to shape it as we move forward. But to start with, as you see on the slide, we have 4 domains or focus areas that we're working on: workforce, rural, practice, and underserved. You might say, wait a minute, that's not what you said last month, because there were 6. We have merged them together, and you will hear as we present and see on the slides how they're connected or interconnected to each other, and we thread partnerships and research throughout. I would also say underpinning workforce, rural, practice, and underserved, it's really done through all three of our missions: education, research, and practice. And so you'll also hear about that. What I would like to stress is the word commitment. And you don't see the commitments on these slides, but you will see them on the next few slides as we walk through each of the 4 areas. Commitments, in some ways, is our commitment to each other as health science deans, to be collaborative, to work together. It's also to the university. It's to our partners throughout the state. But most importantly, our lens we use is our commitments are to the state, to Minnesotans. And so keep that in mind. They're not wordsmith necessarily to the final form that the public would see that, but that is the lens we've been working under. So, next. Next slide.
Chair, committee, and guests. As Dean of the School of Nursing, I have the honor to share the early thoughts of our team related to workforce. So as you can see here, the overall intention is improving the health of Minnesotans. You will hear that theme throughout by addressing healthcare workforce needs throughout the state. We present to you 2 goals, each of which has two strategies. Comments about the first goal, that we are committed to, with your input and refinement, a thorough analysis that both quantifies and assesses the shortages, and if one might say, the gaps, or we call mismatches within the Minnesota workforce. So that is interprofessional, the breadth of the workforce. 2 strategies are proposed to address that. The first, partnering with existing entities, and you'll see the familiarity here with those listed, with the result of the legislative session in which Brooke Cunningham is charged with this situation of creating an advisory board. So we acknowledge that, and we're committed to being a full partner in identifying the gaps and the maldistribution in our state and at the local level. We already have, within my comments, you will see and hear examples where we already have experience and deliverables in each of these areas, which create a foundation upon which we build. In this one, I'm going to use an example of the Center for Nursing Equity and Excellence, which is the official nursing workforce center for the state of Minnesota and represents us within 42 other state centers. All nursing programs in the state of Minnesota work together to identify need, identify gap, and work with the other state and collaborating agencies. I'll move to strategy 2 under goal 1 related to this analysis and assessment. The strategy 2 is establishing health hubs that leverage the University of Minnesota Extension Network that's very, very embedded in our state. And also, as Dean Wellage emphasized, partnership to determine local workforce needs and healthcare needs. So it's both leveraging the resources of the University of Minnesota, particularly the Extension Network, as well as the relationship and partnership and collaboration with our partners throughout the state. Next, I'd like to move to goal 2. Create interventions to address these gaps by leveraging interprofessional collaborations. As you've heard from us before, and always from Dean Toller, we have a 50 to 60 year history and national recognition in being an interprofessional organization when it comes to healthcare working together. We intend to build on that. We are located in a public institution. That interprofessionality spreads across public and private. Strategy 1 emphasizes utilizing the relationships with our system campuses and partnerships in local communities. And it also emphasizes developing and implementing innovative strategies that address this workforce gap. So more of the same, we already know, is not helpful. We have several experiences in this space as well. I've mentioned one, a 50 to 60-year history of all of our schools and colleges working together within an interprofessional goal. You've heard about One Health, where we actually have all of our incoming students are immersed in interprofessionality from the day they come. That also spreads into clinical environment. There are other examples we have which we wish to build on. We have a phenomenal relationship with the University of Minnesota, Rochester, which is devoted to health and healthcare workforce. The School of Nursing is one part of that, of working together for the dire nursing workforce shortage in Minnesota, and also including the Center for Nursing Equity and Excellence in Mayo. So we work together on these partnerships to support Minnesota's workforce. There are many other healthcare resources and education available in UMR that can leverage and partner with other resources across our system campuses. We have phenomenal work going on, as you all know, with UMR, with UMD Duluth, and the intention of building out that campus in the interprofessionality of the health sciences. Also want to mention in particular with local communities, you've also heard about St. Cloud. So it's a wonderful partnership, again, with local community health system, the University of Minnesota, and others to address workforce gaps. By the way, while I might more emphasize examples that relate to nursing, the workforce shortage pervades all of our professions. And then last, I'd like to transition to strategy 2 under creative interventions. This is all about innovation that lead to the development of new workforce models that support our communities, particularly in the areas of workforce shortage. But when one develops new workforce models, it actually can pervade the whole state through collaborative relationships. So I want to highlight that we are come to you with not only the commitment, as Dean Willage mentions, but a track record of having impact and always working together. I've highlighted some examples that relate to our partnerships with system campuses or the local communities. I might also highlight that in some cases, nursing's one of them, we have memorandums of understanding with all of our system campuses, so we can leverage, if you will, the pipeline through and among the different program opportunities for people. So with those comments, we'll now transition to the next commitment, which is rural.
Thank you, Dean Delaney. So the rural commitment is to equitably advance rural health in Minnesota across the state through academic excellence in interprofessional education, research, care. So spanning those 3 themes and community engagement. And we have 2 goals here as well. So I will be sharing the goals and strategies with, as Dean Delaney did, a few just select examples, and these are just illustrative examples. So as we seek to expand the pool of health sciences professionals that are trained for interprofessional practice statewide, our first strategy is to champion interprofessional pathway programs for rural youth in health sciences careers. So we are already building a pilot program in Southwest Minnesota, for example, to support high school students to learn about health careers across the span of health sciences. And this includes shadowing and interviewing health professionals in their own communities. This is something that's already underway. Something that is in the pipeline is to seek grant funding. The Pre-Health Science Student Resource Center has submitted a grant to build a statewide summer program for high school students to explore health professions careers. And that's just one more illustrative example of a way that we can champion these interprofessional pathways programs for rural youth. The other strategy that falls under another strategy that falls under goal 1 is to emphasize rural curriculum and experiential learning as an area of focus. And this will, of course, involve partnerships with communities. And then this third strategy, before I share an example that illustrates both, is to optimize rural interprofessional placements for healthcare learners. So a few of us had a call with some interprofessional leaders from another state where they have received $14 million from their legislature to fund immersive placements for interprofessional learners across the health sciences to, and this includes veterinary medicine, to live and work in rural communities as a part of their clinical training. And these students, while they're out there doing this, are also doing K through 12 outreach to emphasize that kind of health sciences pathway, help these youth understand or envision themselves as future healthcare professionals when they're in that sort of undifferentiated part of life where they're not sure what kind of health profession they might be interested, or if they're even interested in a health profession, but at least get them excited about STEM. And this example illustrates both strategy 2 and 3. Goal 2 is to be the primary trusted partner for addressing statewide health needs, because partnerships, as Dean Wellage said, are woven throughout our commitments. So strategy 1 is to identify, co-develop, and coordinate and sustain these key partnerships throughout the state of Minnesota. We recognize that we need to build stronger trust and better coordination as we sustain these relationships with our partners in the community, whether that be industry or with other institutions, and that coordination is really important as we are a big and complex university. Strategy 2 is to enhance a robust research program to positively impact rural health. And this is just a timely example. So the CDC recently requested that we expand our animal surveillance for H5N1, which many of you are familiar with as high-path avian influenza. And the surveillance will be in mice, wildlife, companion animals, and also on some on-farm activities. So the bottom line is that producers are sometimes reluctant to have federal agencies personnel on their farms, and are much more comfortable having trusted researchers from the university be a part of this. And this is certainly an interprofessional activity, because although we call H5N1 high-path avian influenza because the mortality is highest in birds, we now know that this affects multiple species. It affects dairy cattle, and we know that there are some cases of H5N1 in people that so far, thankfully, have been relatively low pathogenicity, with the primary health impacts being conjunctivitis, but we certainly want to keep our eye on this because we know from...
I think there's been one death.
One death? Okay, all right. So this is something that certainly requires our attention in an interprofessional capacity. So I will now turn things over to Dean Mace.
I think you're gonna turn it to me.
Oh, I'm sorry, Dean Tolar.
That's okay. I've been
Sitting next to
skipped
me.
many times.
All right, okay, thank you.
I'm very used
Thank
to
you
that.
so much.
Thank you. I'm just following the choreography that Amy, Leslie, and others put in front of us. So the most important thing you're gonna hear from me is what I said at the beginning. Academic health matters to people in the state of Minnesota. It matters to the real people, to the real patients, families, and communities. And I'm gonna give you can read the slide, but I'm gonna give you a couple examples from across the whole landscape that we cover. The first one comes from the interprofessional care and education that we do at the Community University Health Center, otherwise known as COOC. It was started in 1966, long time ago. Well, I was born that year. But the point is that it started with the two graduates of this university that felt that nobody's going to take care of the low-income families in the Phillips neighborhood. So they started this, and then it snowballed. the good deeds and the good deals snowball because people are attracted, such as you are, to doing good for the society. So what happened is that mental health got added, dental got added, then legal got added. Doug's old firm, pro bono actually serves, in that clinic, so that mostly immigrants, mostly people who have not been able to interdigitate with the complexity of the United States healthcare are being helped there. The hero of the story is Dr. Duvati, who is the CEO of the Cook, and those that you have met with her, she's an amazing physician, amazing person, and is exactly the kind of leader that we seek at the University of Minnesota. The example that I have heard when I last visited is a grandmother of 6 that came from Africa. And she's taking care of the people there, she's taking care of her family here, and her blood pressure happens to be 210 over 110. So those of you that recognize these numbers, this is just before you get a stroke. And she just doesn't have time to do. So what happened is that the chief pharmacist that we have at the Coop, she sat down with her, did the pill box, told her this is how you do this, and 3 weeks after that, she's normotensive, she's fine. And see, it's personal for that pharmacist because she herself is an immigrant from Vietnam. And she herself experienced, how difficult it is to get some help and to get some training, in the United States healthcare. I am, of the belief that the talent is distributed evenly in the society. Opportunities are not. And we focus, therefore, intentionally on people who have difficulties come and train with us. And we have more than 250 trainees in Cook every single year. These are in all of our professions. And they end up being ambassadors for this kind of care, this kind of ability to help the society. And when I met with some of the legislators, and I think you have as well, they are attracted to having the same thing in rural Minnesota. So one of the stretch goals of the strategic plan is going to be to establish a similar center in the greater Minnesota. The second example I'll take is from primary care. I'm going to use Broadway Clinic, which again, is one of the centers where we take care of people that have very little money and sometimes very little English. And we try to go to the community and ask what should we be doing with them so that we can be useful. And we learned from some of the communities, such as Somali or Hmong community, that it's really difficult for them in women's health to get cancer screening. So we were able to do mobile mammography, so that the van actually comes with the X-ray, where the patients are. And we have learned that we will not get good enough cervical cancer screening unless we do something that they can do at home on their own. So we have built a kit that a woman can use, so that we get that cervical testing done. Again, this is the practical example of how we humanizing science into actionable forms. This is the added value of these 6 health science schools that it has for the community. And then because we live, we exist to solve problems for Minnesota, both in urban, as I gave you an example, and in rural life. So Mora is about an hour and 15 minutes north from here, and we have one of our practices that is from the rural training of physicians there. And on the 2nd of May, which is a little more than a month from now, and Chair Wheeler would understand exactly the story that I'm going to share, we have a full-term laboring mother at home with a midwife at the Amish community, as is typical, of that. There's a prolapse cord distress, and Dr. Schultz, whom I met, is the leader of that group, gets there, gets her bag, but she's doing really poorly because there is a uterine prolapse. There is a bleeding that's life-threatening. They tie up the uterine artery, pack the uterus, transfer her, to the center in Twin Cities, and then again, she survived. That again is example of how we can credibly stand up in the rural communities and say, this is the value. It's not the papers alone. It's not, our beautiful campus alone. It's something tangible that we do. The last example I'm going to use is going to dovetail to Dean Molgaard's comments about the intersection of human and animal health. We are looking at examples of excellence anywhere. And this one comes from the University of Washington in Seattle that actually has a clinic, One Health Clinic, where people were, visionary enough to say there is a balance of human and animal health and an ecosystem where they exist, and they interchange. So we should be able to grasp this holistically and do something about this. So we are looking forward to get with Dr. Sick and others in Phillips neighborhood, similar clinic established that will use as you of course know, some of you, pets are part of the family. So some of the lower income families actually are committed to their pets almost disproportionately so. And the access of the humans, patients, to the clinic is through bringing their pets to be taken care of. And then, of course, if you zoom it out, it is the zoonoses. You mentioned H5N1, but the unavoidable example is COVID. That little coronavirus, that changed lives of everyone. And this university has been the site of action and intelligence for the whole world. In testing, College of Veterinary Medicine scientists actually discovered the touch point of the spike protein and the cell that then was used to develop the vaccines. And as I reviewed with President Cunningham yesterday, if the monitoring that we are doing around the state, what Governor asked us to do about 2 years ago or 3 years ago, is credible, we are seeing approximately the same number of cases of COVID-19 this quarter as we saw in quarter 1, 2022. So it's not less disease burden, but it's the same level of infection in the community. And my worry is that this is going to become like herpes or EBV that is sort of circulating and mutating in the community. So I gave you 3 examples of how we go about concrete lives and livelihoods in Minnesota. I mean, how important it is that in this world, that from any standpoint, the United Healthcare is a mess. We need people like yourself to do good and to change the trajectory. Thank you. And now, Dean Molgaard, I'm going to hand over my friend.
Thank you, Dr. Toller, and good morning, Regents. The health science schools remain committed to reducing health disparities in Minnesota. There are studies that you very well may be aware of that demonstrate that individuals who come from underserved communities are more likely to return to those underserved communities and after graduation. There's also evidence that students who train in underserved communities are more likely to treat underserved communities in their practice and care for them. Certainly, I don't believe that the burden of underserved should be on the underserved. This should be the work of everyone. And therefore, the schools have programs in which we place students into communities so that everybody is exposed and everybody is better prepared and culturally competent to care for underserved communities. And so our commitment remains there. I will share a few of our strategies and a few of our examples. And so for this reason, our first goal under the underserved commitment is to utilize targeted recruitment and retention initiatives to increase the number of graduates providing care for Minnesota's underserved communities. One of the strategies is to expand our care models into rural Minnesota, specifically St. Cloud, similar to care models that exist in Duluth. One example that I'll shine is the Hope Clinic, which is an interprofessional, student-run, faculty-supervised educational clinic providing access to care to underserved communities, populations, Duluth, especially the unhoused. And so that work is a shining example of the work that could be done in other places. And the pending program that the medical school has in St. Cloud will be a great target for reproducing that type of work. A second strategy is to increase the number of graduates from underserved backgrounds through Metro City strategy pathway programs. Pathway programs have been mentioned before. They're an excellent way to expose young individuals to the health professionals and get them interested in the professions at a very early age. It is also an opportunity to train individuals to better prepare individuals who may already be interested in the health professions. And so really reaching out to our young people at an early point is very, very important. I know myself in dentistry that we've done some studies and we've found that the further and further we go down towards middle school is where we're going to capture people. For dentistry, we found that between middle school and high school is where African Americans in particular make decisions to go into dentistry. And so we know that we have to capture some of these groups at a very, very early age if we're going to get them into these programs. The health science programs have many examples of these programs, many examples. There's at least maybe 24 programs between our schools. But just to list off a few is the Next Gen Med program in the medical school, the School of Public Health Core, the Early Assurance Program in pharmacy, the Discovery Dentistry Program, the Vet Camp, the School of Nursing's collaboration with St. Cloud State. And again, there are many other examples across the health science schools. And next, we also understand that in order to advance Minnesota's ecosystem, it is important for us to expand opportunities to engage the community. And Dr. Toller mentioned some of that with the mobile health initiatives, and that was exactly one that I was going to highlight. In 2020, OWACA launched a program where the health science professionals and students collaborated to go into communities and to partner and to provide services that the community needed. Since that time and that launch of that engagement, we've treated hundreds, if not thousands, of patients through these initiatives. And so we've been able to do wellness checks, immunization, dental services, vision, nutrition, pharmacy, and as well as referrals. And so our engagement in these communities through mobile means is very, very critical. Dentistry, again, has been very, very fortunate to have a mobile dental clinic in which we go across the entire state. And so it is just a great example of things that we will be expanding on. And lastly, we're going to also utilize pedagogical things that we've learned here to expand across and out-of-state locations. And thank you. And now to Dr. Petro.
Great, thank you. Thank you to all the deans and the regents. I'm excited to be here today, and we're going to talk a little bit about stakeholder input. Throughout this process, we've been very committed to working together, and engaging the rest of the community is going to be really critical as we move forward. We anticipate that this work will begin in earnest after this meeting, and there may be tweaks to the process and the surveys based on input from all of you. So over the months of June and July, we're going to have in-person meetings with health sciences faculty and staff. We have a website developed so members of the community can monitor the progress and weigh in. And the dates are all listed on the website. We'll be meeting with health science leaders, the Faculty Advisory Committee on the National Health Sciences, the National Center for Interprofessional Practice and Education, and we are part of a larger university system. So we will be discussing this with the Twin City Deans Council and get input from the deans from the other colleges and schools across the system, including computer science and engineering, CFANS, Humphrey School, et cetera. We do also want to emphasize the system across the state, and we'll be getting input from the UMN chancellors and other stakeholders. We anticipate that we will be bringing in external reviewers, and we've started discussing who these might be, and then members of the governor's task force in July and August. And so we have a survey that we've started to develop that will also be sent out to members of the community. We anticipate that this survey will ask questions such as agree, strongly disagree, and people will have an opportunity to weigh in on the goal, strategies, and outlines, and then there'll be open text boxes for input so people can identify things that we may have missed or that they would like to see emphasized, et cetera. And so I think the hope here was that this would be a co-developed strategic plan, and so I think it would be good to turn it over to the questions for discussion so that we have ample time to do so.
Thank you. Thank you very much. Let me open it up for questions or discussions. Regent Turner.
Thank you, Chair Wheeler. First of all, I love the idea that you took my little story about starting when I was 12 years old in healthcare as a candy striper. I'm so glad you took that to heart and you're hitting up the 12-year-olds, because I can't tell you, it was a whole generation of us that got into healthcare at that age. with the nuns teaching us, okay? So I'm thrilled that we're following up on that. I do have some would like some clarification, even in the future possibly. When you talk about new workforce models, that's going to be something that I'm going to be interested in hearing a little bit more specifics about. What do you mean by that? And just to give you a, in my mind, a scenario, one RN behind a bank of computers manning a whole group of LPNs or something on an ICU floor. Until, you know what I mean? That would be an example of a new workforce model I would not exactly as an ICU nurse advocate for. Okay, that's a worst case scenario, but that's a new workforce model. So I'm going to be really interested in what we're going to mean by that. I know that the School of Nursing, I love the idea, and we did that legislatively, we went around and said that about there should not be one open nurse spot in the state. We need to coordinate that if you can't get into this School of Nursing, you can get into this one over here. And that would be all of them. And I imagine that's what you're talking about, Dean Delaney, when you're talking about plugging people in to where, so that we have all of our spots open. I mean, not open, because we cannot afford to let even one spot go without being filled with somebody who can potentially be a nurse or any of the other health sciences. I will at one point also want to, as far as, and maybe this is more the economic, what are we going to do, and maybe it's on the agenda, as far as the workforce between the East Bank and the West Bank, as far as you got union and non-union, pension and non-pension, et cetera. This is going to be huge. I don't know if this is farther down the road, but just putting it on everyone's radar that I'm going to be, because there'll be some real issues there if the two sides can't get together, okay? So those are just going to be some of my concerns and things that I'll be looking out for. And I, like I said, don't know where it is on the agenda. Also, I had given to Chair Wheeler, we dug up that it actually did pass the legislature. It was a little bit of an iffy, did it actually get through? But that a healthcare assessment
Needs
of
assessment, yeah.
what we have in the state, who's doing what where, that actually did pass. So that was I was able to dig that up. So that'll just add to your workload, so there you go.
Perhaps I could comment on new workforce models. Since they're new, we don't have them defined today totally, and I'll be upfront about that. But we know we have to look at that carefully to meet the needs. But we have been already immersed in evolving our workforce models. And one example is referred to as ECHO, and it uses a hub model where you have experts, perhaps here in the Twin Cities, interprofessional, that support workforce that may not have those individuals. So there may not be a mental health expert in your rural community, but you can connect, and it connects usually through telehealth type approaches, but in a collective fashion. Then telehealth is another explosion of workforce models that can be appropriate or not. But I'm not saying those are the ones that we're suggesting, but we're already in the space of evolving our workforce models, because we know, particularly in rural as well as in some aspects of underserved, those communities, those healthcare workforce members have to be supported. When you only have one healthcare member in a rural community, you can't take a vacation. You can't do anything. And I know it very well from working in New Mexico. And so the way to manage that is to have academic health centers and practitioners such as all of us help to support those practitioners.
Follow. Yes, quick. I know exactly what you're talking about. I was in Grand Marais where they have 14 nurses on staff and maybe one or two doctors. And they have that it was someone who came in with a heart attack. I was there visiting. And that's exactly what they did, the cardiologist on it, to walk them through the whole code blue scenario. So I've seen that in action.
Thank you. Regent Verheugen.
Thank you. Did you have a response? I want to give you a chance if you had something to add to Regent Turner's comment.
Oh, please. Please.
Regent Turner, you raised several key issues. They are within the context of all of our discussions. There are three that I'd like to make a specific comment on. One is an example, and that is virtual nursing, which can be replicated and tested with other professionals. The idea started and was tested at Mayo. It immediately spread to Essentia, and it immediately spread to Alina. And that was through a process of openly sharing, as Dean Toller noted, sharing what we know, and all in the interest of the health of Minnesotans. The virtual nurse project leveraged support for the situation we know, which is we have a lot of inexperienced nurses coming into the system and a lot of experienced persons with precious wisdom retiring. So it leverages that situation. Second comment I wanted to make is, Minnesota is phenomenally unique in many ways, but this is one of them that I've experienced in the 20 years I've been here. And that is, I want to relate it to artificial intelligence. So Minnesotans carry that wonderful commitment of innovation and how it actually affects humanity. And it's that dance that we're called to address, hold, et cetera, when it comes to artificial intelligence. We're not afraid of technology. In fact, we welcome it. But we're committed to the dance on the preciousness that it means to preserving humanity. And an example of that is the interprofessional team that was created. We house it in the School of Nursing, but it's computer science, engineering, some nursing, but actually it's predominantly others, community members, that is doing some of the work with local to national partners on the ethical use of AI in nursing and healthcare. And the third comment I wanted to make is you mentioned union, et cetera, and we have those mixtures going on or potentially going on throughout Minnesota, which you're very familiar with. And we stay committed as a full team to partnership and dialogue and solving these situations together. That's a kind of a different way of saying not facilitating silos.
Right.
We're about dialogue and bringing solutions together that serve Minnesotans.
Thank you.
Great, thank you. Yes, Regent Perhelen.
Thank you. So these commitments are huge, super important, and from my perspective, are critical to the state of Minnesota for all the reasons that you talked about. In looking at each and every one of them, though, there is a cost associated with this, both from an individuals to fill these positions, but also just to build out the infrastructure to financially support these programs. And in looking at the stakeholder input, there are a lot of really technical areas that you're seeking stakeholder input from. One question, and I'll ask both my questions at the same time and everyone can decide who's answering what part of it. Where in here does the outreach to regional development commissions, economic development commissions, large employers in some of these outstate Minnesota locations come? Because we know that employment and healthcare are tied together in different ways, especially when people are looking to go out into greater Minnesota or to attract employees to be able to say that they do have the healthcare support for unique situations, for the underserved communities, et cetera. And so what opportunities are there for that kind of input as far as what they need, but also to see what they may be willing to support from a philanthropic perspective or from a system perspective to kind of buttress the funds to do all of this work. And so those are my two question comments. And maybe you take that back and talk about it, but.
So we haven't identified those individuals yet, but I think you bring a good point. I will say, only as an example, in the College of Pharmacy, for the past 3 years, we have been working exquisitely close at the intersection of healthcare providers and payers. We bring them together regularly in summits, and we've made progress in terms of give and takes, if you will, financially, and understanding more what's needed to change the system. Now, have we had big transformations yet? No. But I will say it led from doing it here in Minnesota to being asked to do it nationally within our field. But I think that same type of thing can be utilized broader with employers and with others. It's getting people together to have important conversations when it's really tough.
I would like to add to Dean Woolidge's comments. Thank you for the question. And what you were hearing from Dean Woolidge, which we all know, it's not a single source. It's the answer to any of this, whether it's gifting or legislative allocation. I'd like to share an example that's happening right now that is a wonderful infusion of money from DEED. It involves 4 health systems and 4 entities for nursing preparation, including the community college as well as our university. And the agenda there is that the health systems in partnership stepped up and they literally pay full-time employment for X number of people in this program. And 2 days of that equivalent full-time is spent in education. So it's a way of bringing people in, supporting them to graduation, and leveraging state money, the health system's money, and working with academia, which will also bring scholarships, to increase the workforce for people that might not have access to it for financial reasons or work reasons. So these persons are employed for 4 years. They're only working a small amount, and the rest is dedicated to education. And there's no required, the health system that's sponsoring them, there's no requirement that they stay there. So I know that sounds strange, but it's opening up the opportunities for people and their flexibility for life after graduation.
Dean Toller, did you have something you wanted to add?
Chair Wheeler, Regent of Verhalen, you're asking the absolutely fundamental question. And in everything that we have ever done, we have always led with the mission. Yes, we are here to serve, but didn't hide behind the mission. So we take the possibilities that exist in rural Minnesota and then look only at the options that are truly credible and doable. 2 examples, in Duluth and in St. Cloud. In both of these instances, we work with the mayor, with the Chamber of Commerce, with the developers, with the philanthropists, with the thought leaders, and that is, how we start. So we do not ever leave this to the sort of the beneficence of this, vague, presence of others, but we always start with the skepticism, actually, and open mind at the same time, so that we can actually deliver business that is sustainable, that is good fiscal stewardship, that is firm and consistent. And this kind of audacious strategy that is consistent resonates very well with at least the 2 areas where I have experience.
Thank you. I'll go to Regent Hibbs. I know we're getting closer on time, and I'll have some comments at the end, but Regent Hibbs.
Thanks, Chair Wheeler. So in the commitments, I'm sure there's discovery and innovation in all of them, because that's what we do. I mean, we start big companies like Medtronics and, United Health Group's pretty big. So, we got a lot going on in medical, so that's good. I think the one thing on rural that I see is that we have capacity at all of our rural campuses right now. They don't line up with the majors maybe that we need, but we have capacity. So I think to Regent Verhalen's comments, I think the marginal cost of changing over would be fairly low on some of these campuses to build those campuses up. in terms of what they're doing. And I know that, you talk about the youth, motivating the youth to go into health science. I think we've already done that. I mean, based on our acceptance rates at our schools, we have way more. I mean, our acceptance rates are very low at all of our University of Minnesota schools. I don't know what M-State is like, but, so, I mean, we have kids that are wanting to go in it, but there's no spots for it. And so if we're gonna, increase capacity, we're gonna have to increase the number of spots. And we have capacity in our rural campuses. That's my only comment. And I don't know how we get there. That's for you guys to figure out, but, and it's kind of a pivot of where we're at right now, I think. So, and it's kids that wanna go into this stuff and they're already in rural areas. We have Morris, Crookston, Duluth. Rochester's doing a good job already, so that's my comment.
Great, thank you.
Yep.
Other comments? Questions?
Just a comment. A lot of you have heard this before, but this is so important, and I'm so glad to hear this and we're moving forward. But the state of Minnesota has not done much to expand this workforce in a long time. I know the most about medical schools, right? So back in 1972, which is 52 years ago, we had the university here and then expanded with the campus in Duluth, which has been like 40, 50 per year. Mayo opened the same year. Same thing, we started with 40, there's about 50 now. And again, the population of Minnesota 52 years ago was 3.8 million. It's now almost 5.8 million. We haven't expanded at all the number of medical people who are educating, and 24 is a start. We got to move forward, and then all the other dimensions of healthcare too is so important. But again, we need to find the students and work every way we can to motivate them and do the things that Doug said that are there. But it's expensive to train. I know certainly medical school is very expensive for training, so we have to have, and I'm sure others are too. We have to have the funds and persuade the people of Minnesota and our legislators how important and crucial this what we're talking about today. I think is very persuasive, and I think as we get out and send these messages more clearly, that can happen. But it's really, really vital, and I'm glad to see we're doing this.
Yeah, thank you, Regent Johnson. I'll just make a few comments and bridge off of yours. First of all, this is a precious resource we have to have these 6 schools here and have them serving the state and beyond. But it's really, and I really appreciate your work. We're starting to be able to tell what you've been doing for so long, but a compelling story of like, gosh, we focus on, the workforce needs of Minnesotans, and boy, we supply the vast majority. We focus on those people who have been left out access-wise, be they in rural areas or be they underserved in any areas. And, we're focusing on the practice part and trying to develop and enhance that in ways that will lead us into the future. So you're starting to give us a story that we can tell, because a lot of the legislatures and other people we met with don't know the story, or it's not as simple. And then you're developing strategies underneath it. So I just want to commend you for getting greater clarity on the strategy. A couple of things I think we'll be looking for as it going on, to Regent Verhaelen's comment, stakeholder involvement, be it other health systems, rural county boards, rural legislators, things like that. How do we do that? And this is where I'll again make the offer, is that sometimes you need strategic help in terms of arms and legs, and sometimes you need it in terms of, it's a science. Strategy is a science. So I would say, and we've always offered, like, if you need support to make sure you're reaching out in a way that requires more of that, looks at other models around and has the strategic science. We have that even in our own house here with the Carlson School and Humphrey School and things like that. So, is there some support you need there? So that would be one question I'd have. I think that Regent Johnson was talking about, we're getting, and it was asked, what are the outcomes of this good work? Because if we can know what the outcomes are, then we can more prioritize what initiatives there are, and then we can prioritize what resources should be used. So that will help us too. And then the last thing I'll say, and I talked a little bit of this with Dean Toller, we're also, one of the questions in our strategic framework was, what specialty care areas are we going to focus on? So it's great about the primary care and looking at new models of care and that will advance. A very capital intensive part based on, talent needs, facility needs and everything are subspecialty areas. So what does that look like? Because then we start to right-size our facilities, we start to know what's east, west bank, and things like that. So that was one of those questions we asked too, and I know that's a different phase of this strategic work, but we'll need to know, gosh, what are we gonna further enhance here in specialty care areas, and what does that mean for team-based care? And what are we gonna do in partnership with others? And that's where that needs assessment that the legislature approved gets to, like, we don't want to have a tragedy of the commons where we're all trying to duplicate efforts. We want to do things together. So those are the things we'll be looking for. Gosh, do you need extra help to get those broader stakeholders and the strategic assistance you need? What outcomes are we looking for? And, in specialty practices is a question that's unanswered, but has a lot of ramifications for the talent we need and the right sizing of facilities we need and a whole lot of other worker questions we need and things like that. So, okay, great. All right. So with that, thank you all. And then I think Dean Toller will move on. We have a Fairview update, and you just recently presented to their board, I understand too, and that presentation was included in our document materials. So maybe we start there wherever that makes sense to you.
Thank you, Chair Wheeler. Thank you, Regents. And let me first give you a quick update on where we are with Fairview and how we continue to engage over the data and how we expect that both parties will share fulsomely the data. And we know very well that the better the sharing, the better the product of these discussions. What makes this purpose, this strategic exercise, what gives it a purpose is exactly the benefit of the academic health for the system. So next slide. What we have in front of us is a tale of large conceptions, great achievements, some failures, but unquestionably one that has been a product of enormous will and strength. And that is what the Joint Clinical Enterprise that Mr. Herford and my teams have put together some 6 years ago. Now, it is all about real people. So I'll start with the heart and lung machine. You are looking at Dr. Yiannopoulos, who has started with this, but we started in a large room of having this machine that can actually work for the heart and lungs of somebody who has a myocardial infarction or some kind of a heart trouble of that kind. And then, to your point, Chair Wheeler, we worked with College of Science and Engineering to put it in a truck. So if you had a chance to look at the New York Times March magazine, on the cover, we had the story. So we are nationally visible for things like this that have started as a paper, as a manuscript, then went to the Saving Lives, and then, which is really important from the business perspective, it makes a lot of money, a big margin. So the reinvestment in the Joint Clinical Enterprise is a huge part and fundamental part of why this is important. And what you provide as Regents to this university is an environment where excellence of this kind is rewarded. It's a permissive pathway where we can get this done. Next slide. This is about real people. This is Chloe Cox, who had she was 11 years old and developed a tumor. It's called neuroendocrine tumor, and essentially hit the wall with all the possible therapies. And then and I learned this many times in my practice, the patients usually have the best ideas. So she said to her team, just take the whole thing out. But it took Dr. Chinakatla, our Department of Surgery, our transplant team, to do this, to do the pancreatic and liver combined transplant, and essentially saving her life. Next. The second example, this is Lori and Tracy. They are sisters, and they received heart transplants from our transplant team 9 years apart. They had a mutation. Their father died in his early 40s. Uncles died of heart trouble and so forth. This is the same mutation that you may have seen the 12-year-olds that die of old age. It's called progeria. It's very rare, but the mutation, you know what I'm talking about. The mutation is exactly the same. And Dr. Kamdar, who you see on the right, she's exactly the kind of physician that you can only get at the academic medical center, because she covers everything from the genetics all the way to the operating room and the follow-up after that. Next slide. Dr. Adams, unless you have met him, you should. He is spectacular. He is a abdominal transplant surgeon, and we have used the academic support that we have negotiated in the agreement with the Joint Clinical Enterprise to get him here. Okay, these people that I'm talking about, Dr. Adams, Dr. Kamdar, Dr. Yiannopoulos, these are franchise players. They are not just valuable players. You can build teams around them, and that's exactly what we did. And to the comments of Regent Whaler on being diversified on this, we teamed with LifeSource, for example. Kelly White is the CEO, James Hereford, myself, and others put together the donor care unit, because in contrast to the other side of it planning, majority of the patients who are on our transplant wait list die on these lists, because we have a different way of putting donors, into the mix. So again, a center of this magnitude, this donor care center, has been fully funded from the side of the academic support from the Joint Clinical Enterprise. Next one. These are some of the reputation markers that, again, make the point that we are the R&D of the state of Minnesota for health. The 6 science deans that you have seen, what we do at the university outside of the health sciences, engineering, design, Carlson, Humphrey, and all of this together. And this is, again, meaningful to the real people. The COVID-19, of course, I talked a little bit about this. The organ heart transplant for Maddie Smith, she had a mutation in the lungs of the cell called mitochondria, and she would have died unless, she was recognized early and had that transplant done. We are the leaders nationally in what's called paired kidney transplants. Again, the matching is important for how you treat these patients after the transplant with immunosuppression, or not, because if you don't have to do that, they actually don't end up getting cancers and very serious infections, from this. So again, we are leading with our Department of Pathology on this. Our Department of Surgery is number 4 in the nation. This is an incredible position to have. Our family medicine department is number 1 in the nation. Our Department of Pediatrics is number 7 in the nation. These are phenomenal accomplishments, but what they mean is that we are not the only place that does good medicine. There are other places, that do that. Alina, CentraCare, Essentia, Mayo, of course, but there is a uniqueness of sorts in the academic medicine in how you do this, and this is that you make the science actionable. You bring it from the papers that I showed you to the delivery in one swoop, and that is what matters to the real people. Next. Now, as we are taking this very simple equation, which is you take tragic to treatable, you give people the number 1 asset that matters in life, which is time. You give them time to grow up as kids. You give them time to see their grandchildren. You give them time to resurrect something about themselves. In the ECMO, I met with one of the patients who survived, John Sauer. He was 61, got a heart attack, essentially died. ECMO put him back. And I've seen this over and over, how people revalue what they are doing with their lives, how all of a sudden they focus on things that truly matter to themselves and their families typically. And that's what I heard from him. And this is liberating. This is uplifting. This is what we do as a university here. Next. The value of academic medicine, of course, spreads across multiple domains. These are some of the metrics. It is near unbelievable that we were able to get to the top 10 medical schools in the United States, more than $400 million in NIH money in expenditures, more than 50,000 people that are enrolled on clinical trials. I've let some of them, a handful, but I can tell you that the outcome of people, at least in my field of oncology, that are enrolled on the trials versus the ones that are treated by what's called standard of care is about 20%. That's a big deal. 1/5 of the people that have cancer will live, as opposed to not, if you put them on a clinical trial. Now, next, I want to be careful of the time, so I'll share with you 3 examples of the centers that this academic support, this Joint Clinical Enterprise has funded. The first one is to what Dean Delaney mentioned before, which is data. And there is a lot of things you can say about data, but what we have done with the money, we have started the Learning Health System Center with the School of Public Health, and we have benefited tremendously from the leadership of Dr. Melton Mew and Dr. Tignanelli, and we have have put it in the real operational things. So for example, there are unfortunate, unnecessary maternal death from the high blood pressure just before birth. It's called eclampsia. And we have developed what we call HOPE BP for blood pressure, which is essentially a tool whereby you can signal to somebody who can actually do something about it, that that mother has this very high blood pressure that needs to be taken care of. We have built telestroke. This is really important, how you get to the rural community. Dr. Mike Pitt has built what we call Q rounds. So my patients and my colleagues are frustrated because it's really difficult to organize rounds in the hospital so that the parents are present, the nurses are present, the pharmacists are present, the physician, and this is a simple, relatively simple, but really, really important tool that gets everybody organized so that they show up at the same time. Simple, but life-changing. The second is the trauma center that we have funded from these academic dollars that Dr. Bielman, leads. Dr. Bielman, Colonel Bielman, is one of the people I admire the most because he has the battlefield experience, and he was the one who taught me that the battlefield injury is very similar to injury and disease that you have in greater America, greater Minnesota. Long distance, few resources, and what we have learned from what I learned from the military is what's called damage control surgery, which is if somebody is injured, in the field, you cannot transfer her. You have to actually do the surgery on site, stabilize, and then transfer the patient, to this. So we have built a whole system of action, not theory, not just air castles, action in rural Minnesota around this. We have been funded from the Department of Defense. Congresswoman McCollum, was here recently. She was very supportive of this, and I hope that the federal legislature is going to continues to be supportive of this. But again, this is something that makes a huge difference. The last example I give on this is the extension of the pandemic action that we have led, as I mentioned to you, this university, and we opened it up to the University of Minnesota Infectious Disease Institute and brought. So one of the things that I do is I specialize in hiring the best in the world. So we hired Dr. Adams. There's rarely, a competition on this, this level. We hired Damien Fair for MIDB, and I would argue that Dr. Michael Gale, whom we hired to lead this institute, this is the #1 in the world. So what helps in academic medicine and academic health is that we can generate with that support the magnetic field that brings these phenomenal teams here, and at the same time making it a good business and benefit the system, the healthcare system that we partner with in equal measure. And I'm grateful to Mr. Herford, for recognizing this 6 years ago, that this is a winning strategy in the market that is really, really difficult, as everybody knows. Next. Now, these are some of the achievements. We have achieved most of everything that we planned and more. The two that are more relevant than others, I think, is the Blue Ridge rankings. That is what makes this university one of the top research universities, because majority of the research that we do at this university is linked some in one way or another to the medical fields. And the second one that I'm very proud of is the Vizient one, which is the quality and safety, and we have received, and the credit goes to Dr. Benson, Dr. Jacobs, and many others. We have received a Rising Star Award, which is the most advanced in the Vizient quality and safety rankings in a single year. Next. So we are investing back into the system, not just in the things that I talked to you about these life-changing, life-affirming scientific findings that are then translated into very concrete measures. We have also paid for compensation for rooms, for equipment, as we should, in a good partnership. And in this way, we have moved the field, of the partners forward. Next one. Now, where are we headed? So we continue to build upon the investments that we have made. Cardiology is going to be, one of the targets for us because that's where, somebody mentioned Medtronics, the MedTech, Boston Scientific. We have a lot of work that we do together with them. We will focus on geriatrics and aging. This is a phenomenally important thing, as everybody knows, with the baby boomers getting to their 60s and older. This is going to be game-changing. And again, we have number one scientists in the world, Dr. Niedenhofer and Dr. Robbins, that will lead this because we are the first place with Mayo Clinic, Regents Johnson, that have put together clinical trials on what's called senolytics. These are the medications that take out aging cells so that the immune system is not exhausted. And wait for it, 3 things that take lives of most Americans, which is vascular, meaning heart and strokes, neurodegenerative, and cancer, can all be probably solved by taking out the aging cells. Now, our motto for this is we work hard so that you all can die healthy. So, next.
Just that we're really at time, so yeah.
Last sentence, I'll say, the most important thing is that the academic support is essential, and academic health is essential for the state of health in Minnesota. Second, it pays off. It's good business. It's a good investment. And third, it is about the real people. As Lori, Tracy, Maddie, John, as I told you, this is about people like you and I, and I'm very grateful for you supporting this effort, and I'm grateful for you all making the lives of Minnesotans better. Chair Wheeler.
Thank you, Dean Toller, and I know that was your presentation that you gave to the Fairview Board, showing, a lot has been done through this joint clinical enterprise, right? A lot of good has been done. I love the individual stories and the more collective. Can you give us a snapshot of where we stand today? We're to have a definitive agreement by the end of September.
Thank you,
That
Chair
seems very
Wheeler. And
close.
it's a difficult point, in our relationship. But as I mentioned at the beginning, we are fully committed, both parties, to sharing the data. We expect that the data on the letter of intent, that we, previewed in this committee will be shared fully, and that we will have through summer. We will develop models that can then be actionable in the fall.
Okay. Are there other questions? I know we're tight on time. Okay. Well, thank you very much, and thank you all for being here. With that, this meeting's adjourned.
Someday, someone's gonna give you an Academy Award. Like, it's so into your presentations.
Yeah, very kind. Yeah, very kind.
That's all the elephants, though.
Yep.